Hello, and welcome to Nuance in Advanced Nutrition Support for Critically Ill Patients presentation. Our speaker today is Kristen Burry. Ms. Burry is currently an Advanced Practice 2 dietitian at the ICU Center for Human Nutrition Digestive Disease Institute at the Cleveland Clinic in Cleveland, Ohio. Additionally, she co-chairs the research committee at the ICU at Cleveland Clinic. Ms. Berry has published several peer-reviewed journals. Additionally, she has presented at numerous conferences throughout the U.S. on various nutritional support topics. Our speaker has no disclosures. Continuing education. This activity is approved for one MAA PRA Category 1 credit. The accreditation statement is below. This activity is also provided for one contact hour for pharmacists. The accreditation statement is below. This activity has been approved for one contact hour for nurses and 1.25 contact hours for dietitians. The accreditation statement is below. The link to obtain the credits will be provided at the end of the presentation. And now I will turn our presentation over to our speaker, Kristen Burry. Kristen, welcome.
Thank you for that introduction. So the objectives today will be to discuss the diagnosis of malnutrition and how to monitor and evaluate these high-risk patients. We will evaluate the importance of appropriate protein dosing for critically ill adults. Also, we'll identify the role of lipids in parenteral nutrition and review the literature of intravenous lipid emulsions used in critical care. Finally, we'll discuss the importance of using indirect calorimetry to determine metabolic needs for critically ill patients. First, I want to discuss inflammation and nutrition because I think it's important to understand what acute stress does to our body and how this affects a patient's malnutrition status and their recovery. When the body experiences a stress state, even from a planned surgery, catabolism ensues and impacts post-op recovery. The acute stress response creates inflammation that is highly orchestrated, and it's a complex process which attempts to benefit the host, but it also can impart several negative consequences on the body. During the inflammatory response, a cascade of clinical and biochemical events starts as soon as 24 hours from the onset of illness, like things such as infection, trauma, surgery, or burns. This response is led by pro-inflammatory cytokines, which are the chief stimulators for regulating acute phase proteins. Inflammation promotes muscle catabolism as well as inhibits protein synthesis and muscle repair. During this metabolic response, resting energy expenditure increases and amino acids exit muscle to travel to the liver for gluconeogenesis to meet the need for more acute phase proteins. Our positive acute phase protein production takes precedence, like CRP and ferritin, which are needed for the immune response and tissue repair. And the negative acute phase proteins, like albumin and pure albumin, are downregulated. This combination of increased resting energy expenditure, sacrificing lean tissue, creates a constellation of anorexia, lethargy, and it makes it very difficult for patients to repair and heal. So the importance of early nutrition support. To help mitigate the effects of this intense immune response, it's important to start nutrition support early. We cannot pick where we burn calories from. And in a stress state, the glycogen stores from the liver are depleted within 24 hours, and then the body will catabolize skeletal muscle to mobilize amino acids. And in fact, up to 15 to 20% of our total body protein is metabolized in the first week following trauma or illness. And even if a patient has an excess of subcutaneous fat, our adipose tissue will not be mobilized into fatty acids for energy during the stress state. This does not happen until the starvation state. Furthermore, metabolism during trauma and sepsis can be increased. Your metabolism from trauma or sepsis can be increased up to 20 to 60% above basal energy expenditure. So patients who are malnourished coming in have less reserve to begin with. And additionally, the patients will have an altered fuel utilization, as we discussed on the previous slide. Here is data showing how we cannot pick where we burn calories from. On the left, we have resting metabolic rate, which we can see increases exponentially following any major stress. Even with a planned, uncomplicated surgery, we see that the metabolic rate is increased nearly 1 month post-op. Similarly, the graph on your right in the green shows that nitrogen excretion is significantly increased during the post-op and stress phase. It's important to follow your patient's closely and have an ongoing assessment of protein provision. In fact, it's recommended that protein should be assessed independently from energy, since many critically ill patients have proportionally higher protein needs compared to calorie needs. And these vulnerable patients can be difficult to feed with their precarious environment. Now we will discuss the importance of identifying malnutrition in the critically ill patient. Most of us may be familiar with the Aspen guidelines for diagnosing malnutrition, which evaluates etiology, whether it be acute, chronic, or social, as well as 6 characteristics, including weight, intake, muscle, fat, fluid, and functional status. Registered dietitians do a head-to-toe physical exam and combine that with the current state of the patient to determine a severity of malnutrition. Recently, the Global Leadership Initiative on Malnutrition has come together to establish further guidelines. The basic principles are the same as Aspen, evaluating etiologic criteria like inflammation and reduced intakes, as well as phenotypic criteria regarding weight loss in a physical exam. GLIM is not meant to replace the Aspen guidelines, but rather supplement them. Additionally, GLIM is an excellent tool for institutions where access to a dietitian is limited, and the physicians and independent practitioners are evaluating malnutrition without the help of a credentialed RD. Now we'll discuss emerging body composition tools and how we can evaluate them in the critically ill. First, we'll talk about bedside ultrasound, which has been a long-standing staple in medical diagnostics, but it has recently emerged as a quick and easy tool for RDs to use. The ultrasound machine emits high-frequency sound waves that pass from a transducer to the skin, and the sound waves bounce back at various frequencies to allow for differentiation among tissues, depending on their density. The advantage is that ultrasound is a quick and portable tool, it's inexpensive, and it can be done routinely to measure acute changes over time. Ultrasound can be prone to technical errors, though, which can be controlled with practice. Now, computed tomography, CT scans, also a seasoned diagnostic in the medical toolkit. Now, we can evaluate both muscle size and muscle quality, and recent technologies have allowed the RD to learn and read to quantify these muscle assessments. CT is very accurate at determining muscle size and quality, but a disadvantage is that it cannot be ordered solely for body composition, but RDs can capitalize on already existing scans ordered for medical purposes. Here is a picture of a quadricep on an ultrasound. You can see the bright white structures are the muscle and bone, the peak of the femur, and the striations of the separate muscles of the quadriceps are interfacing. We can evaluate the size of the quadriceps as well as the quality, looking at the echo intensity. Echo intensity is how dark the images are. The darker the muscle is, the higher quality it is. Additionally, we can track fat changes on an ultrasound. Here is a picture of the same muscle group as the previous page, the quadriceps, but this is of a critically ill patient who is malnourished. We see that their quadriceps is smaller than the image on the previous slide, and it has very little definition, and the echo intensity is high, meaning the less black and more bright white suggests poorer muscle quality. And we see 8 days later, the muscle significantly reduced during his critical illness. It's important to note that for ultrasound, every patient is their own control. One ultrasound tells us very little. It's about the changes over time. And currently there are no standards where X% of loss means a specific severity of malnutrition, but we hope to have established guidelines soon. What we do know is that patients lose a significant amount of muscle when they're acutely ill with little changes to fat during the same time frame. Another muscle group emerging that can be analyzed by ultrasound is the temporalis, which can correlate with nutritional status, and it can be an easier muscle group to assess in the critically ill. Anecdotally, during the COVID pandemic in the ICU, we often observed losses in the temporalis region on the face way before we recognized any losses in other larger muscle groups. Here's a picture of the area to assess using a linear probe. Measure the distance between the top of the helix or the cartilage and the crest of the eye. The midpoint of this landmark is called the short angle, and you can see the image of the ultrasound on the right. Once you get the short angle, you flip the probe horizontally to vertically, and this is called the long angle. And just like the quadriceps, we can measure acute changes in the temporalis muscle over time. Switching from ultrasound to CT for body composition, let's talk about skeletal muscle index. A low SMI can indicate sarcopenia when functional assessments are performed and combined with the evaluation of the muscle size and quality. The image here is a picture of the cross-sectional area of a CT scan at the lumbar third vertebrae. The area in yellow is the subcutaneous fat, the pink is the muscle at L3, and the orange is the visceral fat. At L3, we can measure the muscle size and quality. We take this area in pink and divide it by the patient's height in meters squared to get the SMI. And an SMI has sex-specific cut points that indicate if a muscle is low or of poor quality. Here is an example of a patient of mine. He's a 7-year-old male, and the nutrition-focused physical exam revealed no muscle or fat loss, and his BMI is 30. But if we read his CT scan, we see that his SMI is 30.6, which means he has low muscle based on the guidelines for men. So originally in a patient where we would not have been alerted to malnutrition, if we're able to incorporate CT in our assessment, we're aware of his malnutrition early on and can hopefully intervene appropriately. Now let's talk about nutrition support interventions for the critically ill patient. Ideally, you should start enteral support in the critically ill within 24 to 48 hours of the onset of illness, and then advance to goal over the first week. It's important to consider where the patient is in their critical ill journey. For example, your ICU day 1, as you meet the patient, may or may not be their ICU day 1. If a patient is of high nutritional risk or they're severely malnourished, the attempt should be to advance to goal enteral support as soon as possible, while simultaneously monitoring for refeeding syndrome. If a patient is refeeded, it's recommended not to withhold nutrition, but rather replace electrolytes assertively and continue to advance gradually to goal while monitoring the clinical picture. It's important to follow your patients closely and have an ongoing assessment of protein provision. As I mentioned before, it's recommended that protein should be assessed independently from calories, since many critically ill patients have higher protein needs than calorie needs. For the route of nutrition support, of course, the enteral is the preferred route to maintain gut integrity. But in many critically ill patients, especially surgically critically ill, tolerance is an issue, especially if the patient has malabsorption. When enteral is not tolerated, or even in cases where enteral is not infusing appropriately and consistently enough in the first week, supplemental parenteral support is used. In patients with either high or low risk, the clinician should not consider supplemental parenteral support until ICU day 7 to 10. But if a patient is high risk or severely malnourished, we should start supplemental PN as soon as possible when EN is not feasible. Incidentally, the clinician should avoid using PN or supplemental PN in severe sepsis or septic shock because this patient population has an exaggerated stress response and handles exogenous fuels poorly, and the risk-benefit ratio with PN may be problematic. Here is the Aspen 2022 critical care recommendations to further explain the last slide. Based on current recommendations, it's not advisable to initiate supplemental parenteral support before day 7 of the intensive care unit, as there's no significant difference in clinical outcomes. But I want to draw your attention to the box where it states that malnourished patients with limited lean muscle mass were not included in any of these trials. So patients who are high risk or severe malnutrition, we should consider parenteral support starting it earlier following their ICU admission when EN is not an option. Of course, clinical judgment is important, evaluating the risk versus benefit of starting PN. Personally, in my practice, in my moderate and severely malnourished patients in the surgical ICU, when the use of enteral is not possible right away, I am starting parenteral support as soon as possible to meet their high substrate demand during the acute stress response. In appropriate candidates where PN or supplemental PN is started within the first week of the ICU, the PN should be reduced slightly in non-protein calories, but meet full protein needs. This is hypocaloric PN. And this method of parenteral use has been shown to reduce infectious morbidity, hospital length of stay, and hyperglycemia. The clinician should then gradually increase PN to full dextrose calories and incorporate lipids when available. Again, highlighting it's important to note the heterogeneity of critical illness, and many patients don't come to you on a perfect ICU day 1, so just really appreciate where they are in their critical ill journey when you're evaluating when to start parenteral support. Based on the Aspen 2022 guidelines for adults, question 3, we see identified that there's no significant difference in clinical outcomes between early exclusive PN and early exclusive EN during the first week of the ICU, meaning that both PN and EN are acceptable feeding modalities, and there's no evidence to suggest that one is superior to the other. The quality of evidence for this is high, and the strength of this recommendation is strong. This recommendation is based on more recent data compared to the 2016 guidelines. High quality data from large multi-center trials, which suggest modern nutrition support practices have reduced the risk of bacteremia. We have better catheter care, and the risk for hyperglycemia is more improved with glycemic control and the use of insulin in the TPN. In addition to compounding PN, multi-chamber bag PN is an option that is also available. Here is a component comparison of the multi-chamber parenteral nutrition products that are currently available. These are standardized, commercially available PN product formulations available from a manufacturer. They require fewer compounding steps before administration. The two-chamber PN consists of dextrose and amino acids in separate chambers with volumes ranging from 1 to 2 liters. There's an option to include electrolytes, and the amino acid concentration is higher in the 2-chamber bag per liter compared to the 3-chamber bag. Lipids are not included and must be added separately. However, in a 3-chamber bag offers dextrose, amino acids, and lipids. They're all in separate chambers with various volume options available. Currently, there is no electrolyte-free chamber bag option. The lipid content in the 3-chamber bag is soy-based. Now that we've talked about the route of feeding, let's discuss the estimation of macronutrients in the critically ill. First, we'll talk about energy needs. Here is the ICU dosing guidelines from 2022, with a recommendation to feed anywhere from 12 to 25 calories per kilo in the first 7 to 10 days of an ICU stay. For protein, the goal range is 1.2 to 2, and we'll talk about protein extensively in later slides. Here is a chart of the estimation of energy needs in the critically ill based on the data from the previous slide. And this is when indirect calorimetry is not available. For a patient with a BMI less than 30, it's recommended to feed 25 to 30 or 35 calories per kilo of their actual body weight and 1.2 to 2 grams of protein per kilo. In a patients with a BMI from 30 anywhere to 50, it's recommended to feed 11 to 14 calories per kilo of their actual weight and at least 2 grams of protein per kilo of their ideal body weight, and upwards of 2.5 grams of protein per kilo ideal body weight when the BMI is 40 to 50. In patients with a BMI greater than 50, it's recommended to feed 22 to 25 calories per kilo of their ideal weight and 2 to 2.5 grams of protein for their ideal weight. Indirect calorimetry remains the gold standard to assess energy needs, and it allows clinicians to measure patients' varying needs throughout their care. The use of IC is associated with decreased ICU and hospital length of stay, reduced rates of infection and mortality, and an increase in ventilator-free days. In 2018, Gonzalez-Granada conducted a study to investigate whether nutrition therapy with indirect calorimetry instead of equations for assessments of energy need could improve the nutrition status of critically ill patients. The primary endpoint was the change in nutrition status and prognosis. There were significant improvements in reaching energy and protein goals and shorter length of stay with indirect calorimetry when compared to calculated equations. Here is another study, a prospective observational study with 886 mechanically ventilated patients, where energy targets were guided by indirect calorimetry, and at least 1.2 grams of protein per kilo per day was provided. There was statistically significant and then a notably 50% decrease in 28-day mortality by meeting energy and protein needs together. This example protocol may be used to assess appropriate candidates for IC and for the inclusion of IC into daily practice. This is not meant to replace clinical assessment of individual patients, and clinical discretion should be used to determine the need for indirect calorimetry to evaluate the results and choose the right nutrition support regimen. So in the early acute phase, days 1 to 2 of illness, it's recommended to assess appropriateness for the indirect calorimetry and feed 70% of your measured REE if you're able to obtain indirect calorimetry or your calculated REE. In the late acute phase, days 3 to 7 of illness, we should obtain indirect calorimetry measurement if we're able and increase the feeding prescription to 80% to 100% of needs. And in the post-acute phase, after day 7, we should feed 100% of our measured REE if we have a cart, or our calculated REE. We should repeat indirect calorimetry every 2 to 3 days as able, as the clinical condition changes. So further implementing indirect calorimetry into practice in the ICU and beyond. During the first 3 days of illness, calories and proteins should be gradually increased to target in a stepwise approach with a 25% daily increase. By day 4 in the ICU, calorie intake should equal REE of the indirect calorimetry. And a target 1 is 1.3 grams of protein per kilo per day and 70% of calculated caloric targets, or 100% of targets when measured with indirect calorimetry. Target 2 should be met after ICU discharge. For target 2, calories are increased to 125% of predictive equations or indirect calorimetry, or 30 calories per kilo, and a protein prescription of 1.5 to 2 grams of protein per day. And after hospital discharge, target 3 recommends a higher caloric target, up to 150% of predictive equations or indirect calorimetry, or 35 calories per kilo, and an increase in protein of 2 to 2.5 grams per day as they've left the hospital and continue their recovery. Now let's transition from calories to lipids in the critically ill patient. Lipid injectable emulsions, or ILEs, are intravenous lipid emulsions that provide a dense source of energy, 9 to 10 calories per gram, and essential fatty acids to prevent fatty acid deficiency. They contain alpha-linolenic acid and linoleic acid, and lipids can reduce the need for high dextrose delivery and are associated hyperglycemia and morbidity and mortality in patients. So it's really helpful to get that additional calories from the lipids to be able to use less dextrose. And additionally, ILEs can help reduce steatosis. Injectable lipid emulsions are all different and unique in their composition, their FDA-approved indications for use, their essential fatty acid content, and their dosing and variability and compatibility. In the US, soybean oil has been around since 1996 and was the only ILE available until Nutrilipid and SMOF were approved for use by the FDA. Let's talk about the lipid sources for use in PN in the United States. First, there are 100% soybean oil-based ILEs such as Intralipid and Nutrilipid, used both in adults and pediatrics. They are a major source of omega-6 polyunsaturated fatty acids, including the essential acid linoleic acid. They also include essential omega-3 fatty acids, linolenic. But because soybean oil is based ILEs are high in polyunsaturated fat, they are prone to peroxidation. More recently developed are the olive oil-based emulsions, such as clinolipid, which is 80% olive oil and 20% soybean oil. This lipid is indicated for adults and is a good source of omega-9 fatty acid, oleic acid. It's high in monounsaturated fatty acids, meaning there is a greater resistance to peroxidation. Next, we have a fish oil-based lipid called Omegaven, which is 100% fish oil and a source of omega-3 polyunsaturated fatty acids. It also has EPA and DHA. It's indicated in pediatrics. This lipid is high in polyunsaturated fatty acids, so it is prone to oxidation. Finally, we have a 4-oil lipid emulsion called SMOF, which is comprised of soybean oil, MCT oil, olive oil, and fish oil. It's a good source of omegas 3, 6, and 9 fatty acid. It's high in polyunsaturated fatty acids, so it's prone to oxidation. This fat is used in both adults and pediatrics. This graph depicts the difference in composition for ILEs available in the US with a composition breakdown. All of these ILEs are approved for adults and pediatrics with the exception of Omegaven, which is only indicated in pediatrics. Back to our 2022 Aspen guidelines for question 5A. In adult critically ill patients receiving PN, does the provision of mixed oil ILEs as compared with 100% soybean oil ILEs impact clinical outcomes? The choice between a mixed oil ILE or 100% soy-based ILEs for adult critically ill patients receiving PN does not have a significant impact on clinical outcomes, and either option is acceptable. However, the quality of the evidence for this recommendation is low and the strength is weak, indicating that more research is needed to provide a stronger recommendation. Now to question 5B on the right. In adult critically ill patients receiving PN, does the provision of fish oil containing ILE as compared to non-fish oil containing ILE impact clinical outcomes? In the recommendation, there was only one outcome with a significant difference, but this was not supported by data covering other key downstream outcomes. So this suggests it's acceptable to use either fish oil or non-fish oil containing ILE for critically ill patients who are appropriate candidates for PN, including in the first week of the ICU. However, the quality of this recommendation is low and the strength is weak, indicating that more research is needed to make a stronger recommendation. Let's take a closer look at olive oil containing ILEs. This large, prospective, randomized, open-label, multi-center, non-inferiority study in China assessed the delivery, efficacy, and safety of soybean oil PN and olive oil-based PN in patients admitted for hospital for surgery who required parenteral support for at least 5 days and up to 14 days. The results showed the olive oil-based lipid emulsion was associated with significantly fewer infections when compared to the soybean oil-based PN group. Here is a narrative review of 115 studies in the biological and clinical aspects of an olive oil-based lipid emulsion. More than 20 years of clinical experience has shown olive oil-based lipid emulsions are well tolerated and effective for meeting nutritional needs. The evidence shows olive oil-based ILEs are not associated with adverse events on the hepatobiliary system, and in fact, they may preserve immune and endothelial function and reduce plasma lipid levels. Additionally, studies available showed olive oil-based ILEs resulted in less lipid peroxidation. Another review looking at fish oil containing ILEs in adult PN. This was a review of 34 studies which compared fish oil ILEs with non-fish oil ILEs. There was conflicting evidence that fish oil had a beneficial effect on inflammation and the immune response. In 6 of the studies, fish oil significantly reduced IL-6 levels compared to other ILEs. However, in 10 of the studies, it showed no significant difference in IL-6. The evidence does suggest that PN with fish oil does not appear to reduce the risk of post-surgical sepsis or infection compared with other ILEs. Additionally, in terms of mortality, hospital length of stay, and duration of mechanical ventilation, there was no significant difference between fish oil and other ILEs. Here is a meta-analysis of studies that compare olive oil and soybean oil to 100% soy, and then compared a mixed oil emulsion of soybean, MCT oil, olive oil, and fish oil to 100% soy. The study endpoints were nutritional benefit as measured by plasma alpha-tocopherol and plasma fatty acid profile, including omegas 3, 6, and 9. Safety was assessed with a liver panel, including LFTs, T-bili, ALT, and AST. The mixed lipid emulsion, including soybean oil, MCT oil, olive oil, and fish oil, was associated with a higher plasma alpha-tocopherol compared with 100% soybean oil ILE. When compared with 100% soybean oil ILE, the mixed oil emulsion was associated with lower plasma concentrations of long-chain omega-6, higher plasma concentrations of omega-9, and higher concentrations of omega-3. Alkaline phosphatase was significantly higher in pediatric patients with the mixed lipid emulsion, and in adults, alkaline phos, ALT, and AST were significantly lower in adults with the mixed oil compared to the 100% soybean oil. Here's a systematic review and meta-analysis that investigated omega-3 fatty acid enriched parenteral support versus non-omega-3 fatty acid enriched PN in adult hospitalized patients. It included 49 randomized controlled trials with the intervention group receiving omega-3 fatty acids and the control group given non-omega-3 lipid emulsion as part of their PN, covering 70% of their energy provision. There was no control of fish oil dose of the other lipids that were administered alongside the fish oil, and the majority of the studies used lipidem, which is a soy oil fish oil combination using pure fish oil. The relative risk of infection in 24 of the RCTs was 40% lower with the omega-3 fatty acid enriched PN compared to the standard PN. Patients given omega-3 fatty acid enriched PN had reduced mean length of stay in the intensive care unit, as well as a reduced hospital length of stay. The risk of sepsis in 9 of the randomized controlled trials was reduced by 56% in those given omega-3 fatty acid enriched PN. Finally, mortality rate in 20 of the randomized controlled trials showed a non-significant but notable 16% reduction for the omega-3 fatty acid enriched group. Now let's move from lipids to protein needs in the critically ill patient. First, I want to share a study in 2016 by Ye and colleagues where patients admitted to the surgical ICU of the Massachusetts General Hospital were included in a prospective observational cohort to determine whether nutritional status was associated with discharge destination in critically ill surgical patients. Initial calorie and protein targets were 25 to 30 calories per kilo per day and 1.5 grams of protein to 2 grams of protein based on actual weight. And ideal body weight was used with a BMI greater than 30. The investigators then adjusted to account for calories received by propofol and parenteral support. This study demonstrated an association between higher calorie and protein deficit in the surgical intensive care unit with the lower rate of home discharge. So a key takeaway is that providing patients with optimal nutrition is necessary for favorable clinical outcomes and a disposition at discharge. The different phases of critical illness are generally described as the ebb and flow phase, where the ebb phase is the hyperacute early phase of hemodynamic instability, which is usually the reason for the ICU admission. The flow phase includes a subsequent period of metabolic instability and catabolism, which is prolonged, as you see in the early and late periods of the acute phase. Then a period of anabolism follows after day 7. During the early and late parts of the acute phase, catabolism is the dominant metabolic state and adequate nutrition is vital. And I want to point out that these timelines don't always go the way that they're explained. For example, we've all had those patients where they do well, but they return to you and it may be their day 7, but they're still in the acute phase and catabolism. So again, it's important to take these charts and these data and combine it with the clinical judgment at the bedside. The Aspen guidelines recommend a sufficient high-dose protein with a range of 1.2 to 2 grams of protein per kilo in multi-trauma and burn patients. But where does this recommendation come from? First, a prospective observational study by Weiss et al. Demonstrated that 1.3 grams of protein per kilo and energy target was associated with a 50% decrease in 28-day mortality, where there was no decrease in 28-day mortality seen when you achieved energy targets alone, highlighting the point that I've been making where a higher protein provision is important over calories in the acute phase. Next, another prospective observational study comes from Allingstrup with a mixed med-surg population. We see a stepwise decrease in 28-day mortality shown with an increased protein provision. In the low protein provision, the Kaplan-Meier survivor probability was 49% on day 10 as compared to 79% and 88% in the medium and high protein groups on day 10, respectively. Notably, many RCTs show no difference in mortality with high protein. I offer that maybe those who are easier to feed and meet their protein needs are less severely ill, and that may be contributing to their higher survival rather than the protein alone. I thought it would be worth discussing protein recommendations for patients with special considerations. After all, the term critical illness is really a large blanket statement, and there are so many nuances to feeding different subsets of ICUs, whether it's medical, surgical, neuro ICU, cardiac. So we'll talk about those different populations here. First, in renal failure, the recommendations say to feed anywhere from 1.2 to 2 grams of protein per kilo in AKI without dialysis. And once hemodialysis or continuous renal replacement therapy starts, we should feed upwards of 2.5 grams of protein per kilo. I do want to offer that renal failure and critical illness seldom exist as the only organ failing. Most often, if there is renal failure, there's usually other organ systems failing along with it. I have a quote here from a nephrologist that I work with and respect. As you can imagine, dietitians and nephrologists communicate often. Here he says, if someone cannot tolerate the nutrition given their current circumstances, whether it be from sepsis, post-op infection, We would not withhold nutrition just to prevent dialysis because they're not optimally set up for the healing and support that they currently need. Now moving on to cirrhosis and hepatic failure, again, the recommendation is 1.2 grams of protein per kilo of actual weight, but it's really important that we have the dry weight, the driest weight possible. Additionally, it's recommended to avoid protein restriction and liver failure. In patients with an open abdomen, the same recommendation applies, 1.2 to 2 grams of protein, but additionally, it's important to supplement any exudate lost because their protein needs are increased. A patient can lose anywhere from 15 to 30 grams of protein per liter of exudate, whether it be from wounds or even with a high proximal output of your stoma. Continuing on to traumatic brain injury, the recommendation is 1.5 to 2.5 grams of protein per day. For burns, the recommendation is 1.5 to 2. And in sepsis, indirect calorimetry is strongly recommended due to the variability for their calories, but with a protein provision of 1.2 to 2. Finally, the population of the chronically critically ill. More people are surviving critical illness, but they're not returning to their baseline function status before they became acutely ill. This term chronic critical illness is defined as prolonged mechanical ventilation of greater than 6 hours a day, persistent organ dysfunction, or an ICU length of stay greater than 21 days. And for these patients, aggressive high protein plus high calorie provision combined with exercise resistance is recommended. Here, if we talk more about the chronically critical ill, here is a patient of mine with a prolonged ICU stay. This was a patient who came in and had a prolonged critical illness, but then was discharged to a long-term acute care. Here are two of his CT scans, and this is of the same patient. The scan on the left was before his critical illness. He had a BMI of 35, a skeletal muscle index of 50, which is slightly low muscle for men. 52 is and above is what's high, or what's normal, excuse me. But we see that 6 months later, after he's had his critical illness and then went to his rehab center and returned to us, we see that his not only has he lost a significant amount of weight and his BMI is reduced, but his SMI is 37, which means he lost 26% of his muscle at L3 during that 6-month time frame. Additionally, we also see that he has less subcutaneous fat, the area in blue, and we see that the green, which is his visceral fat, has sort of infiltrated past the muscle into the subcutaneous space. Shifting back to protein overall in critical illness, let's look at data specific to protein overall throughout the last several years. In 2019, we had a retrospective study in the Netherlands looking at 455 adult ICU patients. They had 3 categories of protein: less than 0.8 grams of protein per day, 0.8 to 1.2 grams of protein per day, and greater than 1.2 grams of protein per day. The results showed a time-dependent association of protein intake. We see lower protein before day 3 plus higher protein after day 3 was associated with a lower 6-month mortality compared to overall high protein. And increasing protein from days 3 to 5 from 0.8 to 1.2 and then to greater than 1.2 and beyond day 5 was associated with the lowest mortality. I want to point out the overall low protein was associated with the highest mortality. So it may be that we feed patients in a stepwise approach. And I think sometimes this naturally happens in the ICU environment where you're not meeting calorie or protein goals right away early, but then you increase gradually to goal as the patient stabilizes. In 2020, there was a review published of the evolution and current state of protein requirements and provision in acute illness. There are limited RCTs, and there are studies with high protein and high calories or with low protein and low calories. But what about low calorie and high protein, which I feel is the sweet spot for critical illness? The International Nutrition Survey found that in patients with a high malnutrition risk, every 10% increase in protein decreased the odds of death and reduced the time to discharge alive. The bottom left in figure 1, we see early sustained provision of high protein is needed to meet the changing needs, starting in the acute phase and then into the chronic and recovery phase, where both energy and protein needs are high to rehabilitate and restore optimal function. There was a randomized controlled trial in 2015 regarding protein and quality of life, and the results show that high protein provision improved quality of life for every 25% increase in protein at 3 months, but not at 6 months. I mentioned this earlier, but it's important to repeat that early on in critical illness, a higher provision of protein is preferred and should be taken into account over calories. Here, we have the updated Aspen guidelines in 2022. The question is, in adult critically ill patients, does provision of high protein compared to low impact clinical outcomes? There was no difference in clinical outcomes in the relatively limited data, and therefore they cannot make a recommendation at this time beyond the 2016 guidelines. So we continue to aim for a range of 1.2 to 2 grams of protein per kilo. Let's jump to 2023, where the EFFORT trial was published. This was an international, singly blinded, randomized trial. They included over 1,300 nutritional high-risk patients who were adults, and they fed them either high protein, which they deemed as greater than 2.2 grams of protein per kilo per day, or usual protein of 1.2 grams of protein per kilo. Their primary outcome was time to discharge alive, and their secondary outcome was 60-day mortality. The result showed that the incidence to discharge alive was higher in the usual protein group, and the 60-day mortality was lower in the usual protein group. They also did a subgroup analysis concluding that high protein was harmful in those with acute kidney injury and organ failure at baseline. So if you're just reading this abstract, the framing is that high protein is bad. But I want to discuss further details in the study to elaborate on these conclusions. First, if you look at the inclusion criteria and the exclusion criteria and the methods, they specifically excluded those patients where the clinician and physician thought that low or high protein would benefit. So these high-risk patients that we've been talking about, these nuances, they excluded those patients in this data set. Also, they did not specify how they assess protein goals in the extremes of BMI. For example, using 2.2 grams of protein per kilo with a BMI of 35 would not be appropriate at all. So a person with a BMI greater than 35, maybe using an ideal weight in a different range would be better, but they didn't specify that. Third, they did not reach the protein goals. So the high protein group received around 1.6 grams of protein, and the low protein received less than a gram per day. Next, nearly half of the patients enrolled were medical ICU versus surgical, and furthermore, over half of them denied any issues with intakes prior to admission. Over 80% did not have any GI issues or malabsorption. Over 65% did not have moderate or severe muscle wasting. And additionally, both groups had BMIs of 28 to 29, which anyone working in an ICU knows that that's actually a wonderful BMI and has a higher survival rate than a BMI of, say, 18 or 35 or greater. Also notably, enrollment was during the COVID pandemic, so they flipped their primary and secondary aims halfway through. Now, of course, the high protein in AKI could be harmful, but they did not discuss whether AKI meant, are they receiving any type of dialysis? For example, if someone is on continuous renal replacement therapy, higher protein provision is absolutely recommended. Also highlighted in their conclusion was that there are specific subgroups where high protein is necessary, including burns, trauma, surgery, and obesity. So what this study is really showing me that nutritionally low-risk patients who are mainly in the medical ICU, they may benefit from a protein range of around 1.2 to 1.6 grams, which is still within the range of what the Aspen guidelines recommend. Also in 2023, there was a post hoc analysis of that subgroup we talked about on the previous slide, those with acute kidney injury. Again, I want to reiterate that 90% of the patients enrolled were medical, not surgical. Again, we see in those with AKI, a higher protein provision was associated with a slower time to discharge alive and higher 60-day mortality. So it's important to note that the authors reported the protein dose was not significantly associated with the incidence of AKI, kidney replacement therapy, or the duration of kidney replacement therapy. So my takeaways for this post hoc analysis are that once there is an AKI, we should consider modest protein for these patients if there is no plans to dialyze. However, if there is an AKI and kidney replacement therapy is initiated, whether it's intermittent or continuous, we need to increase protein to meet that demand. Also notably, they concluded that higher protein did not cause the need for renal replacement therapy. Now we come to 2024, a systematic review and meta-analysis of randomized controlled trials on the effects of higher versus lower protein in the critically ill. There were 23 RCTs, including over 3,300 patients with protein delivery. Overall, high protein was not associated with mortality. In fact, higher protein plus early physical rehabilitation trended toward an improvement of quality of life and functional measurements at 90 days. Again, we see this AKI subgroup where a higher protein had significant increase in mortality. One last study in 2024, with this population being those on veno-venous extracorporeal membrane oxygenation, or ECMO. This was a retrospective study evaluating protein and energy intake in the first 14 days of VV ECMO. They hypothesized that higher energy delivery would increase ECMO duration, and high protein intake would be associated with reduced mortality, but not the duration of ECMO. They included 178 patients with over 2,000 ECMO days. They estimated needs via the Penn State equation, or using 18 to 22 calories per kilo of their actual weight, or 20 to 25 calories per ideal body weight in cases of obesity. Also, patients were prescribed high protein based on their BMI, as you see in the table on the bottom right. The results showed significantly shorter ECMO duration in patients with obesity who received high protein, with a p-value of 0.037. Also, there was a significant independent association for each increase in percent protein delivery of odds ratio of death when adjusting for confounding factors. That higher protein intake during the first 14 days of VV ECMO was associated with a lower mortality. So after we've gone through the last several years worth of data on protein, when do we restrict and when do we not restrict? After evaluating the evidence, the instances where I restrict are when the kidneys are the only organ system failing and there's no plans of dialysis of any kind. Also, in the chronically critically ill who maybe we've weaned off of CRRT and we're hoping that their kidneys rebound, but if their renal labs are uptrending or they're having azotemia, I will dial back on the protein to see if their kidneys will have a chance to recover in order to keep them off dialysis. I also use modest protein in kidney and renal transplants. However, I will not restrict protein when there are multiple organ systems failing, during continuous renal replacement therapy, or if there's a high protein demand such as post-surgical or an open abdomen or high output stomas or wounds. And of course, in instances of trauma, burns, and major critical illness infection, I will not restrict protein. So where is the future of protein for the critically ill? Possibly with the role of intermittent or bolus feeding to optimize absorption of the high protein demands when there's many ICU interruptions. I think a major piece is not only the emphasis on early and appropriate protein delivery, but in conjunction with early mobility. After all, during acute illness, all the protein in the world will not increase our lean body mass without strength training. I think a stepwise approach to feeding patients based on what juncture they are in their critical illness and tailoring that feeding plan for the long-term critically ill is imperative to support their healing and hopeful improvement in functional status. And of course, the future for RDs is to utilize body composition tools to evaluate lean and fat tissues changes more accurately than our physical exams alone. When we talk about monitoring and evaluating our patients for their malnutrition status, again, I think serial measurements of bedside ultrasound will be important, as well as capitalizing on any CT imaging we have to evaluate the muscle size and quality. Also, a newer measure showing promise is urea to creatinine ratio, where a higher ratio is associated with worsening muscle catabolism. But at the end of the day, the clinical picture of the patient is so important. How do they look? Are they weaning from the vent? Do they have more hours to trach collar? Are their wounds healing? Are they able to tolerate longer sessions with physical therapy? How's their demeanor? It's so important to be present at the bedside and monitor our patients and use our clinical judgment and combine it with the data that we have. Okay, now let's shift to a case study before we conclude to hopefully incorporate everything we discuss and put it into a nutrition assessment and intervention for a patient that I actually had. We have a 72-year-old male with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, and multiple open hernia repairs with mesh. He presented to an outside hospital with a concern for an enterocutaneous fistula, intra-abdominal sepsis, and necrotizing fasciitis of the abdominal wall. The patient is status post an XLAP and extensive lysis of adhesions, oversewing of an open fistula, a small bowel resection, and he was left in discontinuity with a wound vac. Any transfers to our ICU 2 days later. Here he is on our ICU day 1, but his ICU day 2 or 3. He's intubated and sedated on multiple pressors. The patient's bowel is in discontinuity and he's awaiting return to the OR for connection. The RD is present on rounds and inquires about the nutritional plan and possibly starting parenteral support. We know we're unable to use the GI tract at least through today and into tomorrow, even if he gets reconnected. And we anticipate multiple ORs for this patient given that he has an open abdomen. We have CT imaging on him that shows a skeletal muscle index of 35, which we know is low for a male. So more about the patient. He is quite obese with a BMI of nearly 47. But again, we have CT imaging showing that even though he has an excess of adipose tissue, he has low muscle for a man. And we assess him at moderate protein calorie malnutrition based on muscle losses on our physical and poor intakes prior to coming in. So with a moderate malnutrition diagnosis, even though he's obese, we want to start parenteral support early to support his body. If a metabolic cart is available, it would be ideal, but in lieu of that, we would use the Aspen guidelines of 11 to 14 calories per kilo. With this lower energy intake, we absolutely need to make sure we are feeding high protein and using 2 to 2.5 grams of protein per ideal body weight. And also look at the output from his abdominal wound to match that with the higher protein. We want to make sure we're meeting at least the DRI, the dietary reference intake for multivitamins and multi-trace elements, and anticipate that he may refeed given his malnutrition status and metabolic picture. Here is the start of the timeline for this patient for his ICU and hospital journey. Again, he presented to an outside hospital where he had an X-lap and was left in discontinuity. Then he transfers to our ICU, which again is our ICU day 1, but he's been critically ill for almost 3 days. So being that he's been sick, has had poor intakes prior to going to the outside hospital, and he's still in discontinuity, we start parenteral support. At our institution, we do customized parenteral support, which allows for tailoring of fluids and electrolytes with the ability to change daily. In this first bag, we do a modest volume, high protein, and a slower start with dextrose, both for his refeeding and his risk for hyperglycemia with his type 2 diabetes. We gradually increase dextrose to goal, and we collaborate with the team regarding insulin inside the bag, as well as exogenous insulin outside the bag, and we adjust his electrolytes per metabolic picture. Incidentally, with this patient, we did not use any ILEs because he was on propofol on and off for the ORs. So on ICU day 6, the patient underwent his 3rd OR with us receiving a reconnection of his bowel and a colostomy. In this patient, unfortunately, they were unable to close his abdomen because he had necrotizing fasciitis of the wound, and they were going to be unable to close for a while. So eventually he would maybe need a skin graft or suction from the back to close the wound closer together. So we know that he's got a long road to recovery. Even though his fascia remained open with the VAC, his bowel was back in continuity, and shortly after, we started enteral support. We chose a high-protein, immune-modulating formula with nucleic acids for healing, and the patient was actually strong from a respiratory standpoint and did not need a tracheostomy, so he was actually able to leave the ICU after almost 2 weeks, and we were able to wean parenteral support to his goal of enteral support. Just following through the rest of his hospital stay, he was reassessed and remained at moderate malnutrition, now with some fat losses in addition to his muscle loss. But he was improving with his oral autonomy, and we were able to wean the 2 feeds initially to nocturnal, and then once he proved to consistently meet his oral needs with protein supplements, we DC'd his enteral support access entirely. The patient ended up having a few more abdominal VAC exchanges before DCing to a skilled nursing facility with the hopes of closure or skin grafting in the future. So some practical implications from this case study, which I believe improved his care and trajectory, first was recognizing his malnutrition risk and status, and not just thinking that a BMI of 47 means he has the stores to starve the first week of the ICU. We know that in acute illness, after glycogen stores are burned, the body wants skeletal muscle, and although this patient was obese, he had low muscle stores at baseline based on the imaging. So it was important to start with this hypocaloric PN with low dextrose and meeting high protein needs early. It's important that the RD recognize that day 1 for the patient at their institution did not mean it was day 1 of illness for the patient. I can't tell you how many times I'll have a resident say, well, it's only day 1. And I'm like, well, Yes, but they came from an outside hospital where they were there for a week. So I think RDs are excellent at understanding the timeline and advocating for their patient. We continued to meet the high protein needs and accounted for wound vac losses, all the while kidney function. And we did our best to optimize glucose levels in the PN with insulin in the bag, as well as insulin outside managed by the team. And we adjusted his volume and electrolyte status daily based on his changing needs. We also used his GI tract as soon as medically possible. This concludes the webinar on nuances in advanced nutrition support for critically ill adults. I want to thank everyone for listening, and I want to empower all of my dietitians listening to continue to advocate for your patients. And for any pharmacists, LIPs, or physicians listening, thank you for caring about nutrition and including your dietitian to implement evidence-based care.
Thank you, Kristen, for that wonderful presentation today. I'd like to remind everyone how to get their continuing education credits for physicians, pharmacists, nurses, and dietitians. For physicians and nurses, please visit www.saxtesting.com/RB, register at the site, and complete the evaluation and test to receive your certificate. For registered dietitians, please also visit www.saxtesting.com/RB and register at the site, complete the evaluation and test, and you will receive your certificate via email. For pharmacists, please go to www.saxtesting.com/RB-Pharm, register at the site, and complete the evaluation and test. You will receive your certificate by email with complete instructions to report your CPE. And with that, that ends today's webinar. We hope you have a great rest of your day.